One.
Good morning and namaskaram. I'm Dr. Shivasankar Talai, Chief of Neurovascular Intervention from Medicover at Visakhapatnam. Today we have an interesting case. It's a young lady, around young girl, 22 years, and she is having a brain AVM. Brain AVM is a brain arteriovenous malformation, which is a complex neurovascular disease, and this can rupture, giving rise to brain hemorrhage, or it can cause seizure, headache, and these are the symptoms basically. Once the brain AVM is diagnosed, it need not any treatment unless it is symptomatic. The symptomatic means once the brain AVM has bled, giving rise to hemorrhage, this is a definite indication for treatment. Any AVM which is producing the seizure which is not controlled by multiple drugs is an indication for treatment. And sometimes the AVM can also have a subarachnoid hemorrhage because of rupture of internodal aneurysm. That is also an indication for treatment of an AVM. And when you do an AVM angiogram, if you just see few things, that is an indication for treatment, like if there is an aneurysm at the feeding artery, aneurysm inside the nidus, or there is a large aneurysm in the venous side, or there is a venous stenosis raising the internodal pressure up. These are the conditions where we have to treat the AVM. The other condition is if there are multiple internodal fistula, they can also lead to a lot of venous pressure, leading to increase in internodal pressure, and they also need treatment. So what are the treatment for brain AVM? As I said, once you find an AVM and it is not symptomatic, don't treat it. Once it is symptomatic, the treatments options that we have is number one, we have a radiosurgery, we have embolization, and we have medical management for those AVMs which is not like. So we are going to do an embolization of this AVM, and we will show you how to go about it. Start by AVM. So this is a left parietal AVM. This girl presented with seizure and non-consciousness. That's about a month back. So because it's a recurrent seizure, we are going ahead with this embolization. Next one. So we took this angiogram and took a 3D, which is clearly showing there is an arteriovenous malformation. Arteriovenous malformation means artery means the blood vessel which carries the pure blood. Vein is the one that carries the impure blood, and the in-between nidus, the in-between capillary network is malformed. That's why it is called arteriovenous malformation in between that. So this is the AVM we are going to treat. We have taken a microcatheter. Can you just put the next position? So we have approached from this, the middle central artery, and we have gone into the nidus, and we will start injecting the liquid embolics. Can you see the normal saline? Take that middle apart. So this is the microcatheter one. We have reached the nidus. You see the nidus and the draining vein. What's up? Can you show the microcatheter one? Microcatheter one should be 10. Yeah, series number 10. So you see that we have taken our microcatheter. It's a detachable tip microcatheter, 3 cm, 2.5 cm marker. We'll start with AD. So I'm taking something called the DMSO first. This is a dimethyl sulfoxide, and this is like it will prevent agitation of the liquid embolics. Today we are choosing speed. So the dead space of the microcatheter is 0.27. So we are just injecting 0.27 of DMSO, and once that is done, then we will go into the speed. Another speed 18. Paro, are you ready? Ready, sir. DMSO. So we injected 2.7. Patient should be absolutely still. We can see the penetration. We have kept a close eye on the vein. So the idea will be to take the nidus, to take the vein and to take the artery. That will give us a complete cure of this area. We try to cure it completely or as much as possible, keeping things safe. We are happy with the penetration here. Can we have this timer on, Prasad? We will do a check angiogram and see how things are. Good penetration, we are quite happy. Go back. So this is the nidus and this is the draining vein and this is the artery. So the idea will be to take the proximal part, this is the foot of the vein and the nidus and a portion of the artery. So whenever you are embolizing an AVM, so there are a few things that you have to note, that how will you declare that the AVM is cured? If you have completely closed the vein and the nidus and the artery, then you have completely cured the vein. Suppose, why is it so? Because you have completely closed the vein means you have completely closed the exit path of the nidus. So suppose you have not really treated the nidus 100%. After the embolization, if the patient is safely coming out, everything good, vein has been taken, means you have definitely taken the nidus 100% off. So you're obliged to take that. Otherwise you will end up in complication. So any AVM embolization where we can see the nidus, the vein has been taken, the foot of the vein has been taken, means it has been completely cured. So that is our goal. So it's the ideal situation to get it. Sometimes you may not. So your idea of embolization should be, you should embolize the vein in the last. Because if you embolize the vein in the first and some part of the nidus is still left, you will get into complications. So you should be very careful about it. Reset. So it's important to have a lot of patience when you're doing an AVM embolization. Keep setting, don't leave. Keep setting. So we are not happy with the penetration because we are not able to penetrate in the right. So we will go slow here and I would love the squid to just penetrate forward a little bit. So we will see, we will give a little time and try to understand how it behaves. Maybe a couple of minutes we'll start injecting at about 9 minutes. Reset. For the baby. So if you don't want to encounter all this problem of reflux into the proximal artery, you can do a press support technique where you can go with a secondary catheter and between the detachment zone and the catheter you can actually occlude the segment with coil and let it occlude so that the reflux is not that you can just finish it up, and that becomes a little more expensive with a additional catheter coil anything, but that is a very safe technique as well. Here we go wait for the clot to form so that we don't have proximal reflux, and then we just have a distal penetration. If that is the case, then we can go ahead and as we push the liquid embolics, could be onyx, could be squid, it will go through the nidus and to the vein hopefully. Reset. So solid plug is being formed. Hopefully that helps us in a couple of more minutes. Reset. for the waiting. So in retrospect, there can be a discussion. We could have pushed further into the nidus, but here, once you push further, we just went very distal actually. We saw that we are almost to the venous side. So that cannot be a great idea to do, because you start occluding the vein, and then you will have very less time to rapidly embolize and close this. So going close to the vein and in an AVM nidus, which is just in a solitary venous drainage, is not a good idea. So we just withdrew a little bit. So here it might have to take a little more time than usual, but it's okay. It's okay to be safe and taking time and doing it safely. Okay, so we just have some proximal penetration. Let it go slow. Get me the 12 here. Okay, wait. Far up. We'll continue with that. Okay, give me the 12. This is our proximal penetration. I will still continue with 18. Hold the 12 for that. Alright? No. Reset. Keep the run. Come with the run. Play the last run. Slow, step by step. Okay, next. Next. Alright. Take it. So you see there is still some proximal reflex, so it is taking us very close to the proximal detachment zone, so that's not a good idea. It's better to hold and give a little more time. Show you the last one. Yeah. Stop. Go back. Yeah, in here. So we know that we are safe because we have a vein which is draining into the nidus. So some part of nidus is there, the vein is there, and we know that it's fine, it's perfect. So we just have to watch it. What is it? We are 15 minutes into embolization. Valve is ready. Yeah. Very safe. got a good penetration of the nidus here. So give it a little, but we got some more of nidus here. Stop. Go back. Go back. Reset. How much happened, Rita?
3,000.
Just stop now. You're very close to the proximal marker. Just give me the stop. Little more, little more, little more. Little please. Little up. Little up. All right. All right. So in the last one. So in the last one. Okay. Stop. Go back. Breathe here. Reset. Problem reset. So we don't like we like the distal penetration, but the proximal movement is not so impressive. Okay, lateral. Rotate out. So we can't afford more reflux than this. So we are 20 minutes into embolization. We will go see in about a couple of more minutes. So the different modalities we discussed could be surgery, radiosurgery, and basically radiosurgery is a treatment when the AVM is small, 2.5 centimeter or less in max diameter and does not bled, because it takes about 1 to 2 years for the AVM nidus to be completely obliterated by radiosurgery. If you want an instant treatment, it has to be surgery or embolization. And the embolization technique has improved over the years with the refinement of catheter liquid embolics. Previously we used to have glue, now we have onyx and street. So here we are using street. Reset. Take out the roadmap. Let's go back to the line. Okay, 12 is ready. More 12 is ready. Take more 12. Take more 12. Take more 12. Quickly within 1 second. So that's we are very close to the foot of the vein. You can see we need about half a. This is the foot of the vein, the typical look of it. I would love to have a centimeter of the vein if that is possible, otherwise we are good here. So you can see that beautiful penetration there into the foot of the vein. So I would love to, yeah, you can see the vein beautifully there. So your idea should be to hold up the table, Prasad. So it's a very compact tiger there, which we are feeling, and you see this, compare this foot of the vein over here and this liquid embolic cast. You can understand that you have completely there. So I would love it to go up a little bit. Yes, that's beautiful. We are ready with more 12. Keep shaking it in your hand. So we are well within our permissible limit of the proximal reflex, which is good for us, and at the same time we will continue to move. So it looks like it's almost done. Beautiful. Take one more breath, take one more breath, take one more breath. Reset, reset, reset. So nice, lovely form. We are so happy and comfortable here. So this we are doing it live from Visakhapatnam. I am Dr. Dalai, the Chief of Neurovascular, and the Dr. Vinay Prasad. Murli is our chief cath technician. We have Parvati to help and assist us. Just in silence. Can I have the 12? Is it ready with you, Paro?
Okay, ma'am.
So sometimes you can have opacification of more than that you see in angiogram. Those microniders you will not be able to see in the angiogram, but they are still there. Now I am obliged to obliterate the AVM completely because I have taken the vein. If I leave anything, patient will have a bleed. Can you see there is no venous drainage? That means I have to embolize the vein, the AVM completely, otherwise the patient will land into intestinal hemorrhage descent. So nidus is now been taken care of. So we are just trying to see whether we have some open infection or why we come out. So we have a fantastic stroke meet yesterday with a couple of hundreds more doctors coming and attending the programs in the vein. We don't have to go for you see the vein, beautiful, almost about a couple of centimeters of the vein you have taken. That's good enough, that's clean. So this vein will never, this artery, this AVM will never come back because you did perfectly what has to be done. Alright, so we're very convinced that there is no AVM left in this. And just show me the angiogram. Show me the nidus there. The only the AVM nidus, the fluoro. Fluoro. Just do a fluoro. Take out the line. Yeah. So this is the artery, this is the nidus, and this is the vein. When we started the case, I told you take a part of the vein and the nidus and the artery. That means you have completely cured the vein, and you have not crossed beyond your proximal marker if the plug is concerned. So I'm not going to inject any more to use. We have cured the AVM here. A fantastic team we have to support. So I gently pull my catheter, which got detached. See this catheter? This is the detachable catheter from valve, and you can see the markers here. And the part of the catheter we left inside. So this is the best possible embolization that will you ever see from the AVM. Absolutely live, absolutely pure. So with us we have Murli, I am Dr. Dalai, Dr. Vinay, Parvati, Prasad, Nayamat from Bharat. Thank you for your attention. If you have any questions, any doubt, please let me know. We have Gauri also. So we have a fantastic anesthesia team supporting this work, and this is a complete cure of the AVM without any complication. Thank you and namaskaram. If you have any question, post it in the Facebook feed.
Alexa.